For generations, the medical consensus has treated the cardiovascular system like a simple plumbing model, where blood vessels are pipes filling with excess fluid, and the heart is a mechanical pump straining to push it all through. If pressure builds, the standard solution seems obvious. Cut dietary salt so the fluid stops retaining water, run on a treadmill to pump it out, and take generic pills to drain the pipes. But that model completely falls apart for certain patients. Imagine a teenager who eats clean and is in peak physical condition, yet their blood pressure continuously creeps up, a pattern running through their entire multi-generational family tree. By their 40s, the baseline pressure sits dangerously high. Without warning, it suddenly escalates into a life-threatening crisis, sending them straight to the emergency room. In the ER, doctors rely on standard plumbing patches. They inject intravenous beta blockers to force the heart rate down. The heart slows, but the high pressure refuses to drop. They try ACE inhibitors to block kidney hormones. The monitor still doesn't budge. With normal scans and blood work across the board, doctors fall back on a euphemism, essential hypertension. It's a clinical term that simply acknowledges the pressure is high without knowing why. Finally, they inject a different medication, an IV calcium channel blocker called nicardipine. Within 20 minutes, the blood pressure crashes down to a healthy baseline. That sudden drop is the absolute proof. The high pressure has nothing to do with excess fluid or a racing heart. The pipes themselves are locked in a permanent physical squeeze. To understand why these arteries are locked in a spasm, we have to look past the visible organ and shrink down to the smooth muscle cells lining the artery walls. Every smooth muscle cell requires a highly specific electrical signal to contract and maintain pressure. That signal is a fraction of a millisecond flash of calcium. The surface of your artery cells contains millions of voltage-gated security doors called calcium channels. This family inherited a genetic glitch building doors with broken locks. Calcium continuously leaks into the cell's interior. This endless leak forces the tissue to tighten into a chronic spasm. The kidneys monitor this screaming high pressure and trigger a systemic panic response. Doing exactly what they are designed to do, they completely shut off the production of an enzyme called Renin to halt fluid retention. This explains why those standard ER drugs failed. Because the kidneys have already dropped renin levels to near zero, prescribing a renin-blocking ACE inhibitor is delivering a ghost pill. There is no biological target left to block. This is a strict vascular channelopathy. It is a mechanical failure of cellular gates that traditional volume-based systemic drugs consistently misdiagnose and fail to reach. This mechanical failure also explains the deep clinical misunderstanding of salt sensitivity. For this profile, salt does not hold water. It acts as a direct molecular trigger for vascular spasm. This is the sodium-calcium exchanger pump. Normally, it pulls sodium in and throws toxic calcium out. However, this patient's cells are already overloaded with leaked calcium, creating an unstable electrical environment. A wave of dietary sodium forces this unstable pump to run completely backward. Instead of clearing the cell, the reversed pump pulls a tidal wave of excess calcium inward. The cell floods, and the artery violently clamps shut. This introduces a scientific paradox. Calcium channel blockers are actually exceptionally potent when this patient eats salt. The salt surge forces the cell to rely entirely on those leaky calcium gates, making the pharmaceutical block highly effective. If the genetic leak is the initial spark, there are environmental factors that act like pouring gasoline onto the fire. The first involves the artery's native shield. Your endothelium produces an invisible gas called nitric oxide, which signals the artery wall to open up and relax. But many individuals with this profile also carry an MTHFR genetic bottleneck. This breaks their cellular methylation cycle, leading to the toxic buildup of a metabolic byproduct called homocysteine. Here you can see how high levels of homocysteine act as a direct vascular toxin. The jacket molecules aggressively collide with and neutralize the protective nitric oxide gas, stripping the artery of its ability to force relaxation. The second environmental factor is alcohol. It systematically disables every single remaining cellular safety feature in the cardiovascular system at the same time. First, alcohol acts as a severe diuretic. It forces the kidneys to aggressively flush structural magnesium and potassium straight out of the body in the urine. Second, it destroys the liver's ability to utilize B vitamins. This creates an immediate, sharp spike in homocysteine that wipes out any residual nitric oxide. Third, as the alcohol clears the system hours later, the brainstem releases a flood of adrenaline. This acts like a direct electrical shock to the tissue, forcing the leaky calcium gates open even wider. A patient with this calcium handling defect who drinks alcohol and ignores their methylation cycle is functionally disarming their entire cardiovascular defense system. To override this genetic trait without relying on escalating doses of pharmaceuticals, the solution requires building a continuous molecular shield to fuel the cellular pumps and chemically lock the gates. This begins upon rising, on an empty stomach, with the morning ionic defense, potassium bicarbonate mixed with raw lemon juice or apple cider vinegar. The highly alkaline bicarbonate reacts with the acid, creating carbon dioxide gas. This yields potassium citrate and acetate, two highly bioavailable forms of elemental potassium that rapidly flood the bloodstream. This massive potassium rush powers the sodium-potassium pump. It actively spins, pulling potassium inside while pushing sodium out. Without sodium, the neighboring NCX backup pump stops running in reverse, stabilizing the cell and neutralizing the genetic salt sensitivity. 30 minutes later, the main shield is deployed. Amlodipine establishes a 24-hour baseline lock on the outside of the leaky calcium gates. Concurrently, mixing trimethylglycine, or TMG powder, into a morning drink acts as a backdoor donor in the liver. It completely bypasses the MTHFR bottleneck to rapidly clear toxic homocysteine and rescue the nitric oxide gas. This morning protocol achieves two goals simultaneously. It stabilizes the cell's internal electrical gradient with potassium while clamping the physical calcium leak from the outside. Throughout the day, taking small staggered doses of magnesium taurate provides internal defense. The magnesium acts as nature's competitive calcium blocker, operating like a physical wedge inside the cellular gates. As evening approaches, taking vitamin K2 with dietary fat locks down the continuous nighttime shield. This specific step targets structural danger. Decades of high-pressure calcium leaks subject the arteries to risk of calcification, where the body patches stress by depositing hard calcium into the walls, turning soft tissue into rigid pipes. Look at the wall cross-section here. Vitamin K2 activates a specialized mechanism called matrix GLA protein. It operates like a magnetic vacuum, extracting hard calcium deposits to restore flexibility. This framework is built on a testable hypothesis. Because every biological mechanism is measurable, the model can be objectively validated through three specific diagnostic tests. The first requirement is a plasma renin activity blood test. As seen on this lab report, we must physically document a suppressed renin value explicitly below 1.0, proving exactly why ACE inhibitors fail. The second requirement is a total plasma homocysteine test. This physically measures the broken vascular methylation pathway, allowing doctors to track its repair over time. The third requirement is clinical-grade next-generation sequencing. These genetic panels explicitly scan the CACAN1C and CACAN1D genes to locate the precise pathogenic mutation. Clinical confirmation of these three specific markers redefines the patient's diagnosis. It replaces the catch-all term of essential hypertension with a specific biophysical map. By shifting the focus from an arbitrary number on a blood pressure cuff to the specific biophysics of the cell membrane, this model offers a way to address the fundamental biological driver of the condition, rather than just managing its symptoms.